الليكتشر اليوم راح تكون هي طبعا راح أكمل بعد ما أعطتكم دكتورة ميل مكنزي ودكتورة هديل العتيبي ال basic principles بال biopharmaceutics and pharmacokinetics. I will build up and continue on their talks and discussions. So I will talk today about the creatinine clearance and dosage adjustment in renal and hepatic diseases. Okay, so our main concern today is to calculate the dose adjustment in both common disease cases which are the renal and hepatic diseases. Why these diseases? Mainly because first of all they are very common, plus they have a significant impact on the pharmacokinetic of a drug in the patient body concerning the absorption, distribution, metabolism, and elimination. So the objectives of our class or of our lecture today, sure I will continue with a similar book. The reference for our lecture for today is exactly the book that you have been studying from during the earlier weeks in this semester, which is the Applied Biopharmaceutics and Pharmacokinetic. So our objectives of this lecture will be that at the end of this lesson you should be able to calculate the patient creatinine clearance using an appropriate equations. You should be able to calculate the dosing adjustments for renally excreted drug in patients with various degrees of renal impairment or dysfunctionality, as well as you will be able to evaluate the degree of hepatic dysfunction. So we will discuss first of all the renal impairment and the dose adjustment in renal impairment patients. Then we will discuss the hepatic dysfunctionality and the dose adjustment in hepatic dysfunctionality. So you should be able to calculate the dose of a drug eliminated by hepatic clearance in patients with various degrees of hepatic dysfunction. First of all, we will start with the renal diseases. Concerning the renal diseases, we will discuss the issue depending on certain parameters that will help us to determine the degree of the renal failure. We will depend mainly, or the major parameter is the glomerular filtration rate, GFR. which is primarily glomerular filtration is the primarily elimination route for many medications. As all of us know that the major route for drug elimination outside the body is through the kidney, and mainly the drug is metabolized through the liver. So these are the main issues that we are talking about during this lecture. So the kidney functionality is usually measured by determining the value of the glomerular filtration rate, which is typically between 120 and 140 milliliter per minute. Glomerular filtration from the glomerular tubes in the kidney. So it will be between 120 and 140 milliliters per minute in young healthy adults and between the age between 18 to 22 years. Sure, you know that in the elderly the glomerular filtration rate will be the similar case with the other biological organs. Its functionality will be decreased with increasing the age. So the glomerular filtration rate in the elderly will be reduced below this value, which is 120 to 140 milliliter per minute. So as the human age is increased, so there is a gradual decline, so that by 65 years of age, the average glomerular filtration rate will be decreased up to 50 to 60 milliliters per minute. So the classification of chronic kidney disease in the United States standards will be according to this table. So the chronic kidney disease could be classified into stage 1, stage 2, stage 3, which subdivided into stage 3A and 3B, stage 4 and stage 5, which will be subdivided into 5D and 5T. So to start with stage 1, which is a minor disease conditions, kidney disease conditions, there is a kidney damage with a normal glomerular filtration rate, where the glomerular filtration rate as milliliters per minute per 1.73 meters square is above or equal 90. The normal value, just previous slide, has been set to be 120 to 140 milliliters per minute. So if the patient is in stage 1, the GFR will be a little bit less than 120 to 140. It will be above or equal 90 milliliters per minute. This is for a human body that his body surface area is 1.73 meters square. So to remind you with the body surface area, this is for an adult male weighing around 70 kilograms of 168 centimeters, his length or his tall. So for stage 2, sure, the GFR value will be reduced much more than the 90 ml per minute. It will be around 60 to 89 milliliters per minute. So there is a kidney damage with a mild decrease in the GFR. Here, kidney damage with normal GFR in the first stage. Now, this is the second stage. So, if I want to ask you now, guys, that if there is a reduction in the glomerular filtration rate, so what are the consequences concerning the drug that is mainly eliminated through the kidney or renal route? So the drug will be accumulated inside the body. It will result in the toxicity. Okay? So we don't want there to be buildup of the drug or accumulation inside the body. For this reason, the drug needs dose adjustment. So in this lesson or in this lecture, we will be able or we will learn how to make those adjustments for patients with kidney dysfunctionality. And next, at the end of the lecture, for patients with liver dysfunctionality. So, concerning the third stage for the kidney disease, it is stage 3, which is more classified as stage 3A and stage 3B, where we have a low risk of progression to kidney failure. This low risk of progression to kidney failure, where the glomerular filtration rate is decreased more. It will be reduced into 30 to 59 milliliters per minute. And for 3A, which is a little bit better than 3B cases, 3A, the glomerular filtration rate or GFR will be between 45 to 59, while for 3B patients it will be between 30 to 44. So the condition become worse and worse. It's bad. For stage 4, there is a high risk of progression, stage 4 of kidney failure or kidney disease. High risk of progression to kidney failure. The GFR is reduced more and more. It will become 15 to 29. Okay. What about stage 5? Stage 5, there is a complete kidney failure. Either the patient is in the 5D stage with continuous dialysis procedures, or the patient is in the 5T stage where is the transplantation of his kidney. He needs to be transplanted, his kidney, where the GFR is less than 15 milliliters per minute. Okay, so as we have discussed previously, as the kidney disease is in advanced stages up to the transplantation, so there is a need to the GFR will be reduced more and more. The drug will be accumulated inside the body, resulting in toxicity levels. So there is a need for those adjustments. Now we have five different approaches where we will rely on to adjust the doses for patients with kidney failure. Okay, what are for sure each approach will apply to specific cases or specific conditions. So we'll talk about these conditions at each stage. Okay, or at each method. So the first method to calculate or to make those adjustments for patients with kidney problems or dysfunctionality will be the modified of diet and renal disease equation. Modified of diet and renal disease equation, MDRD equation. Okay. In these equations, we will calculate, and the five different approaches, we will calculate the GFR value as well as we will estimate the creatinine clearance value. Okay. So in the first equation, which is the modified of diet renal disease equation, which is MDRD equation, the equation is, so we will calculate in these approaches the GFR as well as the creatinine clearance. Based on the creatinine clearance, then we will make our appropriate dose adjustments. The GFR for the patient will be calculated in milliliters per minute per 1.73 meters square, which is the body surface area of an adult male. adult male. So the GFR will equal 186 multiplied by the creatinine serum to the power minus 1.154 multiplied by the age of the patient. It will be in years. The age will be to the power minus 0.203. Okay. The results should be multiplied by 0.745 if she is a female, and the results should be multiplied by 1.21 if he is a black, if the patient is black. So what does this mean? That you are calculating the glomerular filtration rate for an adult male with a body surface area of 1.73 according to this equation, which is 186 multiplied by the creatinine serum to the power multiplied by the age in years to the power. Okay, so if she is a female, after you have your result, you will multiply it by 0.742. Why? Because naturally the GFR value for female is 74.2% of that corresponding to the male. It's less than that of the male, the GFR value. For the black racing people, it will be higher. You will multiply the value by 1.21, so it is 121 more than the value for the adult male normal value. So as I have told you previously, the 1.73 meter square is the body surface area for an adult male with a height and weight approximately. His height is 5 feet and 10 inches and his weight is around 70 kilograms. Try to calculate the slope. Take the slope is y2 minus y1 by x2 minus x1. Okay, you will get the 1.303 slope value. So the non-creatinine clearance equals to 20 milliliters per minute in patients with moderate to severe heart failure. Look at this. For digoxin, the non-renal clearance will equal 20. It has been decreased, the non-renal clearance. So there will be accumulation of the drug inside the patient body. So we should take care and make those adjustments and decrease the drug doses to avoid the toxicity of the drug and the buildup of a drug concentration inside the patient's blood. But it will remain what the non-renal clearance of digoxin in our case will remain 40 milliliters per minute in patients with no or mild heart failure. It hasn't been affected. Okay. Creatinine concentration should be collected at the midpoint of the urine collection. While the patient is urinating, usually the patient is in the healthcare. So at that time, we should take a blood sample and determine the serum creatinine concentration. So the third approach, so we have talked the first approach about MDRD equation, then the food drug approach, and the third approach will be Cockcroft and Galt equation. Okay. As you are seeing in the beginning of the slide, we have a link. Please go to that equation, to that site, an online site, and try to practice it by yourself. Sure, we will have tutorial at your tutorial session. Okay, where I think that your tutorial session will be, let us check. Okay, it will be next Tuesday Also, there will be a recorded lecture will be downloaded to you by me or Mrs. Naifa, Dr. Naifa Danezi. She will continue with me concerning the tutorial session. So you will practice that link at the time or during tutorial. Please try and practice this link by yourself at home. Okay. So the estimated creatinine clearance will equal 140 minus the age multiplied by the body weight, age sure in years of the patient, body weight in kilograms, divided by 72 multiplied by the serum creatinine concentration, which is milligram percent. Please take care for the units, or milligram per deciliter. This equation to calculate the estimated creatinine clearance for males. Okay, but for females, according to Cockcroft and Galt equation, these are the names for the scientists that have been proposing these equations. The estimated creatinine clearance will equal what? It will equal 0.85 multiplied by 140 minus the age by the body weight divided by 72 multiplied by the creatinine serum concentration for female. Look at this, 0.85. So the estimated creatinine clearance for females is 85% of that of male. It's 0.85 value. It's less than that for male. So here is the estimated creatinine clearance. It will be in the unit of milliliters per minute. The age will be in years, and the body weight will be determined in kilograms, and the creatinine, serum creatinine, will be determined as milligram percent. Now this equation, which is Cockcroft and Galt equation, should be used only in patients with the age, as I have told you previously, that each approach will have its own conditions and circumstances. Concerning Cockcroft-Galt equation, the patient should be in the age of more than or equal 18 years. So the adolescents or the children cannot be apply the Cockcroft-Galt equation. They should be with a weight of 30% of the ideal body weight plus minus or 30%. So how to calculate the ideal body weight? According to Devon formula, Devon is the scientist's name. The ideal body weight for males is 50 plus 2.3 multiplied by the height minus 60. The height now is not in centimeters, it should be in inches. Okay, height in inches, you know that 1 inch will equal 2.54 centimeters. So if your height, say, is 160 centimeters, okay, so if your height is 160 centimeters, so we'll divide 160 by 2.54. It will end up with 63 inches. Okay. So Devon equation for calculation of the ideal body weight um, for ideal body weight for male, it is 50 plus 2.3 في الهايت بالإنشز minus 60. For females, the ideal body weight will equal 45, which usually less than that of the male, plus 2.3 height minus 60. Okay? It should be also in feet. If the serum creatinine values were not stable, the Cockcroft and Galt equation cannot be used. So we have three conditions that are a must for application of Cockcroft-Galt equation to determine the serum creatinine. First of all, it does apply for patients above or equal 18 years. The patient ideal body weight or the patient weight should be 30% of the ideal body weight, i.e. it should be, you are calculating the ideal body weight plus minus 30, not more than this range, plus if the serum creatinine values measured are not stable, so you cannot apply the Cockcroft-Galt equation. Okay. The fourth approach, so we have talked about the MDRD, food drug approach, administration approach, and the third one, the Cockcroft-Galt equation. What about the fourth, which is the Jelef equations? Okay. If the serum creatinine values are not stable, okay, but they are increasing or decreasing in the patient, so as we have said previously, the Cockcroft-Galt equation cannot be used to estimate the creatinine clearance in such a case. So in such a case, an alternative approach must be used, which is suggested by Jelef, which is a 4-step method. The first step in this method is to estimate creatinine production. The formula for this is different for males and females due to gender-dependent differences in the muscles mass between females and males. So first of all, we should be able to estimate the production. The other equations, as I have told you, it's a 4-step equations. For Jelef method, calculating the correct creatinine production of renal function, and then you will adjust the estimated creatinine clearance value according to whether the renal function is getting better or worse. The equation was here, as you can notice by the number 1 written in the blue box at the right of the slide. So this is the second equation, which is the corrected excreted creatinine, and next you will have the third equation, which is the E value equal the or excretion value equal the corrected excreted creatinine calculated from equation 2 minus 4 multiplied by the ideal body weight multiplied by the creatinine serum 2 minus creatinine serum concentration 1 at 2-time intervals, different 2-time intervals by delta t, the time difference. And then you will switch and put this value for E divided in equation 4, as you can see here, by 14.4 multiplied by the average serum creatinine serum, where the creatinine clearance will equal E value divided by 14.4 multiplied by the average serum creatinine or creatinine serum concentration. It will be calculated as milliliters per minute per 1.73 meters square. Sure, you should be able to ask. Please revise your pharmaceutical calculation book to be able to determine the body surface area. If the patient has other than this body surface area, other than that height, other than that weight, you can go back to monograms for the body surface area calculation, or you can go back to the equation for calculation of the body surface area. After you end up with the result here, which is the creatinine clearance value, this value is for 1.73 meters square body surface area. Your patient body surface area, you will multiply the creatinine clearance value by the patient body surface area you have been calculating and divide by 1.73 meters square. So, if the patients are not within the 30% of their ideal body weight, so other methods could be used to estimate the creatinine clearance that should be used. So up to now we have discussed 4 different methods or 4 different approaches to calculate or to determine the creatinine clearance for patients with kidney problems. Specific methods suggested by Salazar and Corcoran, these are other scientists that have been approaching the 5th approach to determine the creatinine clearance for patients with kidney dysfunctionality. These 2 scientists have been proposing a new method for estimating creatinine clearance for obese patients that has been shown to be generally superior. So their body weights is exceeding the ideal body weight by more than 30%. So the previous equations does not apply for these patients. Okay. So according to Salazar and Corcoran equations for obese patients, here are the 2 equations for males and females calculations for the estimated creatinine clearance. As you see that for the males, the equation to calculate the estimated creatinine clearance is 137 minus the age in years multiplied by 0.285 by the weight in kilograms plus the 12.1 multiplied by the height square. Okay, in this case the height, which is the patient tall, is in, as you can see in the slide at the footnote at the bottom of the slide, it is in meter units. Now it's not in inches as previously, so you should be able to take care about the units when you are applying your different equations. Divided by 51 multiplied by the serum creatinine concentration. Okay, so the estimated creatinine clearance according to Salazar and Corcoran equation for obese patients with kidney problems. For female, it is 146 minus the age multiplied by 2.287 multiplied by the weight in the kilograms plus 9.74 multiplied by the height square in meters unit divided by 60 multiplied by the serum creatinine in milligram percent unit. Okay, as you can notice that the denominator maqam in both equations, for females it's greater, which is 60. So as the denominator increase, the end result will be, if it is increased the denominator, so the end result will be reduced. So the female estimated creatinine clearance is less than that corresponding for males. Remember that Salazar and Corcoran equations are for obese patients. Obese above the 30% more than calculating the renal function, which is usually unitless value. Okay, it does not have unit. Now, depending on this renal function equation, we will calculate what the dosage regimen adjustment. The maintenance dose divided by tau, which is the interval between different doses, for the patient with kidney dysfunctionality equal the renal function اللي هي كانت الكرياتينين clearance للدysfunctional patient اللي عنده renal dysfunctionality على الكرياتينين or dividing by creatinine clearance للtypical subject. Okay, so the maintenance dose at tau intervals, which is the dosing interval for D patients with kidney dysfunctionality or renal dysfunctionality equals the renal function multiplied by the maintenance dose by tau for a typical subject. Okay. The adjustment may be made by reducing the frequency of administration or even reducing the maintenance dose or both. So, reducing the frequency instead of administering the total daily dose. For example, 3 times daily to divide the total daily dose by 3 different divided doses. You can administer it either as 2 divided doses or 1 single dose daily. Or even you can reduce the amount of the dose itself. Say instead of giving 500 milligrams per day, you can give, as an example, 300 or 400 milligrams per day. Or we can use the 2 different approaches, reducing the frequency and reducing the maintenance dose. Okay, so we will practice with practical examples whether today in our class lecture or in the next coming tutorial session. We'll practice such forms of calculation. Okay. Generally, we have general guidelines for dosage adjustment in renal dysfunctional patients. As long as the fraction of the drug eliminated by the renal route, which is FE, fraction of the drug eliminated by the renal route, is 0.3 or less, and the metabolites are inactive, so if the fraction of the drug eliminated by the renal route is 0.3 or less and the metabolites are inactive, they have no pharmacological activity, there is no any changes in the regimen, is called for based on the renal functionality. So if the fraction of drug eliminated by the renal route is 0.3 or less, يعني, or by other meanings, i.e. 0.3 of the drug is eliminated by other than renal route, non-renal, so no need for dose adjustment. Plus, the metabolites are inactive, does not have any pharmacological activity. Regardless of the contribution of the renal route, if the renal function is 0.7, that the typical value for a typical patient, no changes is needed. So in these 2 cases, there is no need for dose adjustment. If the renal function is 0.7 or even more, it could be 0.8 of that for the typical patient, 80% of that of the typical patient renal functionality, 70%, 75%, 90%, 95%, no need for dose adjustment. It means that the situation is good and you can manage with and continue. Now let us switch to the hepatic clearance and hepatic disorders. So the 5 different previous approaches are mainly for dose adjustment for patients with renal dysfunction. Now, for hepatic dysfunctionality, the main equation for hepatic drug clearance of the drug through the hepatic route equal liver blood flow multiplied by fraction of free drug in the blood, FB, multiplied by the intrinsic clearance, okay, divided by the liver blood flow plus fraction of a free drug in a blood multiplied by the intrinsic clearance. This is the hepatic drug clearance equation for drug clearance. The intrinsic clearance is the capacity of endogenous enzymes to transform substance, and it's expressed in volume per unit time, milliliter per minute. مثلها مثل الكرياتينين clearance, okay, milliliters per minute. So the intrinsic clearance, it's the capacity of the endogenous enzymes to transform the substance in milliliter per unit time. If the intrinsic clearance in an organ is much lower than the blood flow, the metabolism is to be said capacity limited, okay? So intrinsic clearance, it's the ability of the enzymes, say for the liver, to transform the drug into its metabolites, the metabolic pathway. Now, if the intrinsic clearance is less than the blood flow inside and outside that body organ, okay, if it is less, usually the biological kinetic way or kinetic operation, the that is of the lower rate, it's the rate determining step for that kinetic process, i.e. what will determine whether that blood that is entering, that drug that is entering the liver is to be metabolized and eliminated outside the liver or stay within the liver. We have a lot of factors. One of the two major important factors is the rate of blood flow inside and outside the liver, as well as the intrinsic clearance. Intrinsic clearance, the rate that the enzyme is metabolizing, liver enzymes are metabolizing the drug and eliminating the drug outside the liver. Which rate is less, it will be the rate determining step, okay? Whether if it is the rate of blood flow inside and outside the liver, if it is less, so it's the rate determining step. But if the intrinsic clearance, which is the enzyme metabolism of the drug, is less, so it is the rate determining step, or it's a capacity limited. What do we mean by capacity limited? That the kinetic process of metabolizing that drug by the enzyme in the liver is limited by the quantity of enzyme that is available in liver at that time. If the intrinsic clearance is much higher than the blood flow, then the metabolism is limited by the rate of blood flow. So, which is less, rate of blood flow inside and outside the liver, or rate, intrinsic clearance, which is the rate of enzyme metabolizing the drug? Which is less between these two rates will be the rate determining step for metabolic process of the drug across the liver. We have two major types of liver diseases. Do you remember how do we classify the renal dysfunctionality into different 5 stages, ending up with the kidney transplantation? Concerning the liver diseases, we have hepatitis and cirrhosis. Hepatitis, patients with hepatitis, they do have an inflammation of the liver with decreased ability of the hepatocytes or dying. Okay? Hepatocytes are the liver cells. We have acute hepatitis and we have chronic hepatitis. Okay, the death here is related to the hepatocytes themselves, the liver cells. Acute hepatitis, which is usually mild, transient decrease in the drug metabolism, will end up with transient or resulting in transient decrease in the drug metabolism. It requires no or minor changes in the drug doses. Acute hepatitis requires no or minor changes in drug dosing. For chronic hepatitis, it's an irreversible hepatocytes that they are damaged, irreversible damage of the hepatocytes, requiring drug dose changes. The patients with long-term hepatocytes damage can progress into hepatic cirrhosis. So we have start with a mild inflammation of hepatocytes, which needs no dose adjustment. Then we switch to the chronic hepatocytes where there is a need for dose adjustment, ending up with the hepatic cirrhosis, where there is the permanent loss of the functionality of the hepatocytes, permanent, daim. The drug dosage schedules usually need to be modified. How to be modified? As we have mentioned previously, we will decrease the maintenance dose, as well as we decrease the frequency of dose adjustment. Okay, what are the altered pharmacokinetic parameters during hepatic diseases? When the hepatocytes are damaged, the intrinsic clearance will decrease. What is intrinsic clearance? Back again, it's the liver enzymes metabolizing the drugs. If the hepatocytes functionality is reduced, if they are damaged, so the intrinsic clearance will be decreased. The hepatic clearance as a whole will be decreased. If the drug has a hepatic first pass effect, bioavailability will increase. Okay, what is the hepatic first pass effect? Hepatic first pass effect, metabolism of the drug by the hepatic enzymes that are present in the hepatocytes. If there is a hepatic dysfunctionality, the hepatic normal functionality is decreased, so sure the drug concentration or bioavailability will be increased. Why? Drug concentration available in systemic circulation, Why it will be increased? Because the metabolism by the liver for that drug is reduced. Why the metabolism is reduced for that drug? Because of the dysfunctionality for the hepatocytes. 3. Simultaneous effect of 1 and 2 will result in extremely large increase in the steady state concentration for orally administered drug. So if there is large increase in steady state concentration for systemic circulation, will reach the toxic level. So there is a need to reduce either the dose amount, maintenance dose, or to reduce the frequency. What do I mean by reducing the frequency? I will give you an appropriate example a few slides later. Say we are giving 500 milligrams 3 times daily. So the total daily dose is 1,500 milligrams. 500 milligrams in the morning, after 8 hours 500 milligrams. So initially 500 milligrams at 8 a.m. After 8 hours, which will be at 4 p.m., giving another 500 milligrams. After 8 hours, which will be 12 in the midnight, giving another 500 milligrams. So the total daily dose is 1,500 milligrams. Either we will reduce the total daily dose to say 1,000 milligram. Okay. So the 1,000 divided at 3 individual doses rather than 1,500 milligrams, or giving just the morning dose, which is the 8 a.m. 100 milligrams and the 8 p.m. 100 milligrams, and no other third dose per day. So the total daily dose has been reduced from 1,500 milligrams into 1,000 milligrams. You can take one of the two approaches, either decreasing the maintenance dose by 3 times daily, so it could be around, roughly talking, 305 milligrams, 50 milligrams, 350 milligrams morning, 350 milligrams in the afternoon, 350 milligrams at 12 a.m. So as a total, 1,000 milligram. Okay, or just giving 500 milligram in the morning and 500 milligram at the evening. Number 4 is the liver blood flow. If it is decreased, this will result in depressing the hepatic drug clearance even more and more. So the hepatocytes are they are dysfunctional. The liver blood flow is decreased due to the hepatic problems. So the drug clearance, the hepatic drug clearance, will be even further reduced. The liver will produce albumin and alpha-1 acid glycoproteins in the blood. The production of these proteins, albumin and alpha-1 acid glycoprotein, will decline in patients with cirrhosis. Usually it decreased. So more free fraction of the drug will be available in the blood. So the bioavailability is increased due to a lot of reasons. First of all, the intrinsic clearance, which is the enzyme metabolism for the drug inside the liver, has been decreased because the hepatocytes are damaged partially or even totally, whatever. So the free drug available in the systemic circulation will be increased. Another approach, that a lot of drug are bounded by the albumin and the glycoproteins produced by the liver in the blood. If the liver is not working properly, so these proteins or peptides will not be available in appropriate concentration for systemic circulation. So the free drug available for in the systemic circulation will be increased. Those all will result in toxicity. The drug concentration in the systemic circulation will reach to the toxic level. Since clearance decreases, point number 6, and the volume of distribution usually decreases, and the half-life of elimination always increases, almost always increases. So the clearance has been decreased, the volume of distribution also is decreasing, so the half-life of elimination will be increased. The drug will not be eliminated in a fast manner. It will be staying in the blood for a longer period of time. So a lot of factors will result in increased systemic drug concentration. It will stay in the blood, okay? Either the enzymes are not available in their sufficient quantity because the hepatocytes are diseased, dysfunctional, appropriately damaged. The liver blood flow is reduced. The proteins or peptides are not produced in sufficient quantity in the blood. They will leave the blood free. This will leave the blood free because the clearance is reduced, the volume of distribution is reduced, so the half-life of elimination will be increased. What does this mean? That the drug will stay for a longer time in the blood before being cleared outside the body. Okay, now how to measure the liver function? We have previously measured the renal functionality by the creatinine clearance. The measurement of the liver function, there is no any single laboratory test to assess the liver function, not like the estimated creatinine clearance to measure the renal function. No single laboratory test. A lot of more than one laboratory test and vital signs will be used to determine the liver functionality. The most common way to estimate the ability of the liver to metabolize the drug is to determine the Child-Pugh score for the patient. So in the case for kidney functionality, we have been using what? We have been using the creatinine clearance. In our case here, which is the liver dysfunctionality, we are using the Child-Pugh score method to determine the liver functionality. The Child-Pugh score consists of 5 laboratory tests or clinical symptoms, vital signs, which are serum albumin concentration, total bilirubin concentration, prothrombin time, ascites, which is edema, and hepatic encephalopathy. So we have to determine these 5 laboratory tests and clinical symptoms or signs. Okay. Child and Pugh are different scientists that has been proposing this scoring system for assessing the hepatic functionality. So to start with the Child-Pugh score for patients with liver diseases. Here is the test or symptoms. We have 5 different tests. It has been assigned as score 1 point or score 2 points or score 3 points. Okay, look at this. Total bilirubin as milligrams per deciliter. Serum albumin as gram per deciliter. Again, deciliter means 100 milligram, so it could be here bilirubin milligram percent, serum albumin as gram percent, prothrombin time, which is the seconds prolonged over control. It's measured in second units, ascites, which is the edema, and hepatic encephalopathy. When you are talking about score 3, it's the worst method, the worst evaluation for the hepatic functionality. Score 1 point, it's the less, so the better evaluation for the hepatic functionality. So if the total bilirubin as milligram percent is less than 2 milligram percent, it takes the score 1. If it is between 2 to 3, score 2. If it is above 3, the total bilirubin, which is usually an indication for jaundice اليرقان أو الإصفرار in the patients. Serum albumin, so as you noticed, if it is increased the bilirubin in the serum, total bilirubin, so it is an indication of worst hepatic functionality. Serum albumin, if it is more than 3.5, it should be present in an appropriate concentration in the serum, albumin, okay? It will bind to the free drug. If the liver is diseased, the serum albumin usually, the albumin is produced by the liver. It will be reduced, the concentration of it. If it is reduced to 2.8, 3.5, it is score 2. If it is less than 2.8 gram percent in the serum, it is score 3, which is the worst score for serum albumin. For prothrombin, okay, time in seconds, if it is less than 4, it is score 1. If it is more than 6, it is score 3. It takes longer time for prothrombin time. Ascites, if it is absent, no ascites, score 1. If it is slight, score 2. If it is moderate ascites, it will result in score 3. For the hepatic encephalopathy, If it is not present, score 1. If it is moderate, score 2. If it's severe, score. Each of the symptoms is given of a score of 1 normal hepatic functionality to 3 severely or abnormal hepatic functionality. And the scores for the 5 areas are summed. Okay, so will I sum the score of the 5 areas? If we are talking about the highest score, which is 3, 3 multiplied by 5, if it is a 3, 3, 3 for the 5 symptoms, laboratory tests or clinical symptoms, so it will be a total score of 15. So the value will be ranging between 1 or 5 to 15. So they are summed finally. The child POW score for the patient with a normal liver function is usually 5. It is the least value, the lowest value for the POW score, child POW score. Whereas for abnormal, completely hepatic damage, it is 15. Different textbooks and publications use different measures. Some older references work substitute the prothrombin prolongation to the INR value. A child POW score of 8 to 9. Okay, so 15, complete liver damage, definitely we need those adjustments. 5, child POW score, it's a normal liver functionality. Now, a child POW score between 8 to 9, okay, will result in a moderate decrease, about 25% in the initial daily dose for agents that are primarily more than 60% metabolized hepatically. So two conditions. If the child POW score is between 8 to 9, so it is above than the normal and less than the 5 and less than the 15, which is totally damaged, and the drug is more than 60% metabolized by the liver, okay? If it is less than 60%, the condition does not apply. If both conditions apply, what are the both conditions? The child POW score between 8 to 9 and the drug is above 60% metabolized by the liver, you should decrease the daily dose by 25%, i.e., let us talking about daily drug dose, that is 1000 milligram. As antibiotic, for example, amoxicillin, 250 milligrams given 4 times daily, okay, i.e. every 6 hours. So the 1000 daily dose, we will remove 25, so we'll remove 250 milligram. So instead of giving 4 doses by day, 4 times, we will give only 3 times, each dose 250 milligrams. So instead of giving 4 times, each time 250 milligrams by total daily dose of 1000 milligram, we'll give only 3 times per day, each time 250 milligrams, so the total will be 750 milligrams instead of 1000 milligram daily. A child POW score that is more than 10, you are approaching the complete liver damage. A significant decrease in the initial daily dose, 50%, is required for drugs that are mostly liver metabolized. Come on, you should be assured that the drug is mainly metabolized by the liver, okay? So the drug is metabolized by the liver mostly, again by more than 60%, and the child POW score is above 10, so you should reduce the dose by 50%, i.e. for the previous example, which is 1000 milligrams daily for the let us say amoxicillin or ciprofloxacin antibiotic. So instead of giving 1000 milligram daily, you will just give 500 milligram daily. It will be 2 separate doses, each of 250 milligrams, okay? It is possible to decrease the dose while retaining the normal dosage interval. Okay, so let us talk back again about the 500 milligrams. I have told you just twice daily, 250, 250. Okay, you can even give it the 500 milligram 4 times daily, but instead of giving 250 per dose at each time, you will give 125 milligrams 4 times daily. So 125 milligrams multiplied by 4 will equal 500 milligrams per day. You will retain the usual dose and prolong the dosage interval. Instead of giving 4 times a day with the dose interval 6 hours, just give twice a day with the dose interval 12 hours. Or you can modify both the dose and the dosage interval. It's up to you, but or the patient conditions and circumstances. But the end result that you should decrease the total daily dose by 25% in the first case and by 50% in the second case. Either you will prolong the duration between dose administration, or you will give the dose that is given with a similar frequency of the dosage. For example, the usual dose of medication that is 95% liver metabolized. Imagine 95% above 60 is 500 milligram every 6 hours. So it's given 4 times a day. So the total daily days is 2 grams. 2000 milligram per day, i.e. 2 grams. For hepatic cirrhosis patients with a child POW score of 12, so it should be reduced by 50%. So the 2 grams daily will be reduced into 1 gram per day, or 1000 milligram per day. The drug could be prescribed to the patient as 250 milligrams every 6 hours, 4 times daily, or it could be administered as 500 milligrams every 12 hours. The patient would be closely monitored for any pharmacological, toxicological effects due to the medication administration, and the dose would be modified further and further according to the need if the patient has produced any signs or symptoms improper. Now, the table in the next slide 3.3 give values for the theophylline clearance in a variety of patients, including patients with cirrhosis. As an example, we are talking about theophylline. Theophylline is used as a bronchodilator for patients that are asthmatic. The theophylline dosage rated listed in table, they are designed to produce a steady state. The theophylline concentrations between steady state concentrations, which are 8 to 12 milligram per liter. Look, we are talking about steady state concentrations. They were computed by multiplying the theophylline clearance and the desired steady state concentrations. We are calculating the maintenance dose. So the desired steady state concentration, CSS, is between 8 to 12 milligram per liter multiplied by the clearance. You will achieve the maintenance dose. Let us look at the table for the theophylline clearance and dosage rates for patients with various disease states and conditions. Now, here's the disease state or condition: children between 1 to 9 years, 9 to 12 years, or adults, smokers. Here, the adolescents between 12 to 16 years, or elderly smokers above 65 years, adult non-smokers, elderly non-smokers, and decompensated congestive heart failure, core pulmonary with cirrhosis. The theophylline does have a mean volume of distribution which is 0.5 liter per kilogram. Take care that it could be you should multiply this by the total kilogram, which could be 70. For example, if the patient has a weight of 70 kilograms, so the volume of distribution will be half the 70 kilograms, which will be 35 liter per his total body weight. So the mean clearance will be milliliters per minute per kilogram. Look at this, per kilogram. Back again. If the patient weight is 70 kilograms, you should multiply the value by 70. So say for example children, أعمارهم or their ages between 1 to 9 years. Let us say the children, he is say 5 years old, so his weight is 20 kilogram. So this value 1.4 should be multiplied by 20, which will end up with 28 milliliters per minute. So the mean dose as milligram per kilogram per hour. Look at this, per hour. To calculate it for as a daily doses, you should multiply this dose by 24. Okay, and also per kilogram, so you'll multiply by 20 kilograms by 24 hours, multiply 0.8 by 20 kilograms in our case by 24 hours. Okay, look at these values for the children 9 to 12 years old, adults that are smokers. The mean clearance has been reduced for smokers, so the mean dose is reduced. For adolescents, elderly smokers, also the clearance is reduced, the mean dose is reduced 0.5. For adults non-smoker, the clearance compared to children is 0.7, the mean dose is 0.4. For elderly non-smokers, the clearance will be less, the dose will be also less, 0.3. For decompensated congestive heart failure, the clearance will be less more and more, and the mean dose will be reduced more and more. Decompensated cor pulmonaire is a clinical syndrome manifested by the signs of congestive heart failure in pulmonary disease. The hemodynamic characteristics of the syndrome differ substantially from the classical picture of the chronic heart failure. These are just the characteristics for the disease. The cardiac output is usually normal at rest, but sometimes even during the exercise. Signs of impaired contractility of the right ventricle are absent, and the effect of the cardiac glycosydes is minimal. It's possible that the clinical syndrome of decompensated cor pulmonaire is caused mainly by severe respiratory impairment and subsequent impaired function of some organs, in particular in the kidney. We are talking about the clinical characterization of the congestive heart failure or copulmonary clinical syndrome.